All right, future RNs, let's get ready to conquer the next generation NCLEX-RN. And today we're diving into 3 high-yield case scenarios that will test your critical thinking and get you NCLEX ready. And we'll break down each case with Q&A and simplify the rationales so you really can understand why each answer matters, and also share test-taking strategies to help you tackle those tricky questions with confidence. From spotting red flags to prioritizing patient safety, we've got you covered. So grab your pens, bring your A game today, and let's ace this together. Your nursing license is waiting. And if you find this session helpful, don't forget to like and subscribe to this video for more NCLEX preparation tips.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month. Then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
Let's get into the questions. The scenario states, the family shared that the 37-year-old male client has been struggling with intense abdominal pain for most of the night at home. The emergency department healthcare provider diagnosed acute pancreatitis, linking it to the client's long history of heavy drinking. When the client arrived at the emergency department, he had jaundice, severe abdominal pain, recurrent nausea, and a mild fever. Your task in this question, it says, using the list of options provided, identify the most appropriate choices to complete the statements below. So I just want you to do a quick glance for now, and we'll do this together. So we have here the statements. It says, the nurse understands that the top priority in managing this individual's condition involves blank. And here are the options for that blank. First is treating alcohol abuse, reducing vomiting, controlling pain, reducing fever, improving icterus. What do you think would match that one? The answer to this is controlling pain, because with acute pancreatitis, this is going to lead to severe abdominal pain due to pancreatic inflammation and autodigestion by its own enzymes. And the top priority is controlling this pain to reduce the client's distress and also to improve their comfort and stabilize them for further treatment. And this intervention aligns with Maslow's hierarchy of needs, because we know pain is a physiological need that must be addressed in the acute setting, especially in the emergency department. Now, what about the other options here, such as treating alcohol abuse? Why is it incorrect? Well, we know that alcohol is the cause of pancreatitis, but this is a long-term health promotion goal. It's not the focus on the acute crisis in the emergency department. What about the reducing vomiting? Well, nausea and vomiting are present, but they are secondary to the severe pain in terms of priority, and these two can be managed after the pain is addressed. Now, what about reducing fever? Well, the fever that is described in the case is actually mild, and this is not an immediate threat compared to the severe pain, so it is a lower priority in this context. The last option, improving icterus. This is basically jaundice, indicating pancreatic or biliary involvement, but it is not the primary concern in the emergency department. Pain management takes precedence in this acute phase. That's why we are going to select that one. Let's move on to the next statement. While closely observing for critical complications linked to pancreatitis, particularly blank and blank. So basically you're going to select two problems here in the second column. So what are these two going to be? The answers are hemorrhage and shock. Now, what is going on in acute pancreatitis? Well, this is actually going to lead to life-threatening complications like these two. The hemorrhage can occur if the pancreatic enzymes erode those nearby blood vessels. It can cause internal bleeding, and shock can develop from hypovolemia due to fluid shifting or from the systemic inflammation, which can lead to septic shock. Now, these two are critical risks that can rapidly worsen, so you as a nurse working for this patient should closely monitor to ensure the client's safety. Let's read the last statement. It says, the nurse anticipates that the initial serum enzyme to rise in this individual would be blank. Options are total bilirubin, amylase, there's lipase, we have aspartate aminotransferase, and alkaline phosphatase. What do you think would be the best fit here? Well, the answer is going to be amylase. Why? It's because this is the first serum enzyme to elevate, typically within 6 to 12 hours of the onset of the symptoms. And this is due to the pancreatic inflammation. It can allow the leakage of the enzymes into the bloodstream. And this is a primary diagnostic marker for pancreatitis, especially in alcohol-related cases. And the client's pain stating most of the night suggests an early presentation. And don't forget about the timeline here regarding the pain onset. And this also aligns with the amylase as the earliest enzyme to increase. So it's going to be the best choice to confirm the diagnosis, especially when the client is in the emergency department. Now, what about total bilirubin? Why is this incorrect? Well, this is something that will reflect liver function or biliary obstruction, and this is often linked to jaundice, but it is not an enzyme and it is not the initial marker for pancreatitis. The lipase, this is also going to elevate in acute pancreatitis, but it will peak later, around 24 to 48 hours, while the amylase increases first. And the lipase will stay elevated longer than the amylase, but again, this is not the initial enzyme to increase for this case. Now let's look into the aspartate aminotransferase. This is something that is going to give us an idea if there is liver damage, especially from alcohol, but it's not the specific enzyme to pancreatitis, and it is not the first to increase either. The last one we have is alkaline phosphatase. This is an enzyme that is related to biliary obstruction or liver issues, but it's not the enzyme that will elevate in the early phase of pancreatitis. So we're going to discard this one as well. So when you encounter this type of question, you have to focus on the keywords in the question stem. The top priority, of course, this signals the immediate need for you to address. That is the pain control. And the critical complications that you will be expecting in this client immediately would be the hemorrhage and shock. And also, you have to remind yourself to apply the Maslow's hierarchy of needs here. Again, we are focusing about physiological needs. That's about pain, oxygenation, circulation, and these major issues will take priority over other issues, long-term issues, or maybe psychological issues. And again, controlling the pain should be our first intervention here, according to this case, right? And don't forget to use the pathophysiology that you have learned. Take note that with acute pancreatitis, the severe abdominal pain is the core issue. The same thing with the complications. We have hemorrhage and shock. These are the major risks. And the first enzyme to elevate is the amylase. And so you need to eliminate those other options that are not related, especially like treating the alcohol abuse or the AST, aspartate aminotransferase and alkaline phosphatase. Now, we're going to look back into blank number 1 here. For blank 1, you have to rule out long-term goals like treating alcohol abuse or other secondary symptoms like fever, vomiting. For blank 2, you have to exclude those other manifestations like jaundice or less severe issues. And for blank 4, you have to focus on the pancreatic enzymes, not liver markers or liver enzymes. And you also have to prioritize your options based on the scenario cues. Again, the problem that we are facing here is about intense abdominal pain. And you have to differentiate the similar options, especially for blank 4. There is close proximity between the amylase and the lipase, but then again, our focus for the statement here is about the initial serum enzyme to rise. So you have to pick between the two enzymes, amylase versus lipase. And also, you have to consider the time frame. The case scenario said something about most of the night. It suggests early stage pancreatitis, so it supports amylase as the first enzyme. And the immediate emergency department care should focus on pain and life-threatening risks, not about chronic issues like jaundice improvement. So I hope that you're able to get the rationale for this test item.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
Have our second one. A 68-year-old male patient who recently completed a 10-day antibiotic regimen for pneumonia was subsequently found to have C. difficile infection. Having been prescribed oral metronidazole for treatment at home, the patient now arrives at the primary care provider's office for a follow-up visit to assess their condition. Now, your task in this item is to determine if the interventions were successful, unsuccessful, or irrelevant. So that's why you have the columns over here versus the patient observations that you are going to think about. Now, what about the observation in the first row? What do you think would best fit to this one? It says reports improved appetite. Do you think that this observation reflects successful treatment or unsuccessful or irrelevant? Well, this is something that should be easy, right? That's going to be successful. Because with C. diff infections, this is going to make people lose their appetite. And the reason for that is because the infection can cause the inflammation, it can cause gut issues, even dehydration. But when the client reports that their appetite is improving, it definitely shows the body is getting better and the infection is under control. This means metronidazole worked well to help the patient feel normal again, which is the primary goal of the treatment. Now, for the second statement, it says experiences occasional abdominal discomfort and cramping. Well, this is going to be unsuccessful because with C. diff infection, it's going to make the colon inflamed. It's going to lead to cramping and discomfort. Even though the cramping is only occasional, as stated in row 2, it's still happening. It simply means the colon might not be fully healed yet. And this shows metronidazole did not completely get rid of all the infection effects, which is what we want from the treatment. Now, the third column, it says no presence of C. difficile in the stool exam. This is a successful indicator, right? Because with metronidazole, it kills C. diff bacteria by stopping them from growing. And a negative stool exam means the bacteria are gone, which is the biggest goal of the treatment. So this simply proves the medicine did its job to clear the infection. The next one we have is mentions having 1 to 2 form stools daily. This is also a successful evidence, because with C. diff infections, it can cause watery diarrhea because the bacteria mess up the gut and can cause the inflammation. And when the client reports that they have 1 to 2 formed, again, the word here is formed stools daily, it simply means the gut is working normally again. And this is an evidence that the metronidazole helped fix the problem, which is the key goal of the treatment. Let's look into the next one. It says complaints of persistent watery diarrhea several times daily. Well, yes, this is going to be actually, I'm reading on the wrong row. We're actually on this row right here. Notes painful hemorrhoids. That is going to be irrelevant because painful hemorrhoids probably came from straining when the client was constipated prior to this issue. And this is not a sign of infection now, and it doesn't show if metronidazole worked or not. And since this is not related to the current treatment goals, it doesn't matter for this assessment. Now let's look into the one that I just mentioned. It says complaints of persistent watery diarrhea several times daily. The answer to that is unsuccessful. Why? It's because watery diarrhea, if it keeps happening, it simply means the infection might still be active or the colon is still irritated. Even though the stool exam is negative, this symptom shows metronidazole did not fully stop all the problems caused by the C. diff, which is supposedly the main goal of the treatment. Now, in real life, this might need more testing, but we're looking only at the symptom by the case, so we're kind of limited here. Let's look into the next one. It says reports ongoing nausea after meals. What do you think about this? Well, this is also unsuccessful because nausea during C. diff infection can come from the infection's effects on the gut or as a side effect of metronidazole, which can upset the stomach. And if nausea is still happening after treatment, it means the infection's effects are not fully gone or the medicine is causing some issues. But either way, this shows the treatment did not completely fix all symptoms, which is supposedly the goal as well. Next row we have describes a low-grade fever persisting for several days. This is going to be unsuccessful because a low-grade fever means the body is still fighting inflammation, possibly from C. diff or another problem. And if the fever doesn't go away after treatment, it shows metronidazole did not fully stop the infection's effects or inflammation. And this means the treatment did not meet the goal of getting the patient back to normal health. Let's have the second to the last one here. We have reports a recent increase in thirst and dry mouth. This is going to be irrelevant because thirst and dry mouth are not main symptoms of C. diff infection. And metronidazole can cause dry mouth as a side effect for some people, closely about 1 to 10% of patients. And the thirst being mentioned here might happen because of the dry mouth or maybe another reason, maybe dehydration and other issues. But then again, these symptoms don't tell us if the infection is gone or if the gut is better, which are the main goals of treatment. And again, these two might be a side effect of the medication or something else. Maybe something else that's not quite related to the issue. That's why this is going to be irrelevant. The last one we have mentions a slight increase in urinary frequency over the past week. This is also irrelevant because needing to urinate more often isn't caused by C. diff, which supposedly is going to affect the colon, or by the metronidazole, which is going to fight the bacteria and doesn't affect urination. And this is something that could be from something else, like a urinary tract infection, or it could be prostate issues in the older adult, or maybe diabetes. And since it doesn't show if the infection is better or if the gut is healed, it's not related to the treatment goals as well. So just mark that as irrelevant. So for this test item, you have to focus what the metronidazole or the metronidazole should do. And you have to recall about its drug action, which is basically to eradicate the C. diff bacteria, to stop the diarrhea, and to make the client's symptoms better. So you have to check each observation to show if the goals were met by this treatment. So this is going to keep you focused on the treatment's main goal, so you don't get confused by the things that are not related. Another thing that you need to use here is to utilize what you knew about the C. diff infection and the medicine that is supposed to target the issue. And again, C. diff is going to cause the diarrhea and gut problems, and the medication that is intended to treat this is metronidazole to eradicate the bacteria. But consider that can also lead to some side effects like nausea and possibly dry mouth and thirst. Now, for example, formed stools mean the treatment has finally worked, but a fever means it didn't work. And so another thing that you need to do here is to separate the symptoms from the side effects or some unrelated issues. So what you're going to need to do here is to decide if the observation is from the infection, like diarrhea or fever, or it could be a side effect of the metronidazole, like dry mouth, or it could be something else, like the need to urinate more often. And so these strategies will help you to figure out if the observation may really matter, or it's something that will reflect a successful or could be unsuccessful or an irrelevant clue evidence to the treatment.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get: 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
Let's have our next question here. It states, a 47-year-old male patient who has no known allergies has sustained 30% partial and full thickness burns. Your task is to use the options provided and identify the most appropriate choices to complete the statements below by selecting from the given lists of options. So we have the options here. So let's get into each statement here. There are 5 different blanks that you need to answer. So the first statement says, to prevent hypertrophic scarring and contractures, the patient will need to wear compression garments for at least 23 hours a day throughout blank. What do you think would be the option that's going to best fit? We have the options here: half a year to 1 year, a quarter to half a year, 36 to 48 months, 12 to 24 months. The answer to this one is 12 months to 24 months, because after this deep burn, especially 30% partial and full thickness, the healing process can really go wrong. And the body makes too much collagen. Remember this. The collagen is going to be produced much with this percentage of burns. It can cause thick, raised scars. This is what we refer to as hypertrophic scars. And the skin will tighten too much, and this is what we call as contractures. So this can now limit movement of the client's extremities, or maybe digits, or possibly whatever the site of burn was at. And so the compression garments are supposed to be worn to press onto the healing skin to flatten the scars, and this will guide the tissue to heal smoother. And according to research and burn care guidelines, you need to have this patient wear the compression garment for 23 hours each day, and this can be taken off only for about an hour for the need for them to take a bath or to do skincare. And the reason for this is to make sure that the scars will not do some more of hypertrophy here, because it's going to take about 12 to 24 months for these scars to mature. And it simply means they stop changing and settle down. And for this patient, starting this early and sticking to this use of compression for this duration, it will prevent those complications as well. Now, why not 36 to 48 months? Well, this is way too long, because scar maturation finishes within 2 years in most cases. And after that, the scar tissue is stable and the extra collagen is not being made like it was early on. And so wearing compression garments for 3 to 4 years would not add any benefit and would just frustrate the patient with no real improvement. And this is something that's considered an overkill. It's not supported by burn care standards. So you as a nurse assigned to this client, you need to know the timeline of the healing. Again, extending the treatment beyond what's needed is a waste of time and also the resources. Now, what about a quarter to half a year? What do you think about this option? Well, this is way too short because in the first 3 to 6 months, the scar is still forming and very active. The collagen is still building up fast, and the skin is prone to thickening or tightening. And stopping the compression garment this time would let the hypertrophic scars or contractures form, because the pressure hasn't had time to shape the healing process. And studies show you need at least a year, often more, or at least two years to get the good results. So, key takeaway for this option: short-term treatment will fail to control the long-term healing process. So this is not going to help treat the client this time. Now, what about half a year to 1 year? This is somewhat kind of better to or better than the 3 to 6 months, but again, this is still not enough. We know that some improvement might happen in 6 to 12 months, but scars often need the full 1 to 2 years to mature, especially with deep burns like this one. And stopping at 12 months might leave the patient with partly formed scars or contractures because the tissue remodeling isn't complete yet. And with burn experts, they agree that 12 months is the minimum and 24 months is safer for bigger burns. And so the key point here, it's almost correct, but then again, it misses the full duration needed for the best outcomes. Now for the next statement, it says 18 hours after admission, the patient's blood pressure has dropped significantly, which occurs after major burns due to blank. Here we go, we have the options: patient-controlled analgesia, hydromorphone, or dilaudid, inadequate fluid replacement, sepsis, capillary leak syndrome. What do you think would best fit in here? The answer is capillary leak syndrome, because with a 30% burn, the skin and the blood vessels get badly damaged, and in the first 24 to 48 hours, the blood vessels become leaky. It's going to let the fluids, electrolytes, and proteins to escape into the tissues. And this is going to leave less fluid in the bloodstream, we call hypovolemia, and the blood pressure will also drop. And at 18 hours, this patient is in the peak of this problem called burn shock, which is why the blood pressure is low this time. Now, what about the other options here, such as sepsis? Why not sepsis? Well, we know that sepsis is going to set in when the infection spreads throughout the body. It can lead to dropping of the blood pressure due to the massive inflammatory response with blood vessels vasodilating, of course. And in burns, infections can happen, but they usually show up later, like after 48 hours or a few days, when bacteria grow in the wound. And at 18 hours, it's too early for sepsis to be the main issue. The drop here is from the fluid loss, not about the infection. And the key takeaway here is that timing matters, because sepsis is a later complication and it's not the cause of the drop in the blood pressure around this time at 18 hours. Now let's look into inadequate fluid replacement. Why do you think it doesn't fit? Well, if nurses did not give enough IV fluids, the patient's blood pressure could stay low or get worse, but this isn't the root cause. This option is a treatment problem. It is not the burn's direct effect, and the capillary leak syndrome happens no matter what, and it is the burn itself causing the fluid shifting. And the key point here is that the inadequate fluid replacement is a secondary issue. It's not the primary mechanism the question asks for. Now, the PCA hydromorphone, which is basically the analgesic that we are providing to the patient, it can lower the blood pressure a little as a side effect, because we know that opioids can relax the blood vessels, but it's not the main reason for a significant drop in a burn patient. The huge fluid shifting from the capillary leak is the real culprit here, not the hydromorphone PCA. And the pain management doesn't really explain the burn-specific hypotension. That's why we are going to eliminate this one as well. Now let's proceed to the next statement. Metabolic acidosis is present based on arterial blood gas results and develops in burn patients as a result of blank. What do you think about this one? The answer to that is going to be insufficient oxygen supply to the tissues, because in a 30% burn, fluid leaks out of the blood vessels, It will reduce the blood flow to the tissues, and without enough blood, the tissues don't get oxygen, so they're going to switch to anaerobic metabolism. So they're going to maintain their function without oxygen. And remember that this is going to make more lactic acid, which is going to show up in the laboratory results, causing metabolic acidosis. And this is going to reflect as a low pH. There's also high lactate level. And it's a classic early problem in the burn shock as well. Now, why the other options are incorrect, like impaired blood flow to the tissues? Why do you think that this is incorrect? Well, this somewhat kind of sounds similar to the first one, or the correct answer, but this is less specific because impaired blood flow is part of the problem, but the key issue is that tissues are not getting oxygen. It's going to lead to the acid buildup. The correct answer ties directly to hypoxia, which is low oxygen, right? Which is the most precise reason for the metabolic acidosis, and that's why this is considered as too vague in order to be considered as the correct answer. Now, what about the reduced respiratory rate? Well, if the patient's breathing slows down, the carbon dioxide builds up in the blood. It can cause respiratory acidosis, which is totally a different problem. And here we have an issue with metabolic acidosis, which comes from acid like lactate, not carbon dioxide. And in burns, the breathing might be affected later, especially if there is significant smoke inhalation. But this question focused on tissue hypoxia, not about the lung inhalation of the smoke, right? And so the key point here is that this is pointing to the wrong acid-base imbalance. It's pointing to the respiratory issue, not about the metabolic acidosis. Now, we have elevated bicarbonate concentration. Why is this incorrect? Well, remember that bicarbonate is the body's buffer to the acid, right? And in metabolic acidosis, bicarbonate goes down because it is used up trying to neutralize the extra acid, which is the lactate. And since it states elevated, this would mean the body is compensating too much, or there's a different problem. So it's pointing more towards metabolic alkalosis, not metabolic alkalosis. And so this is simply a contradiction to the issue that we are facing here. Now let's have number 4. It states the initial treatment for metabolic acidosis includes administering blank. The options are anti-infectives, intravenous fluids, high flow oxygen, and sodium bicarbonate. The answer to this one is intravenous fluids. It's because this is the first step in treating metabolic acidosis in burns. We are going to give the client massive IVs. There's going to be bolus and bolus and bolus fluids here. And this is based on the Parkland formula, which is basically 4 mLs, you're going to multiply it by the weight of the client per kilo and also the percentage of the burn. And for a 30% burn, this is going to the IV fluid that we're talking about here will replace the lost fluid. It will boost blood volume and it will get oxygen to the tissues again. And when the body tissues receive more oxygen or blood, they're going to stop making the lactic acid, and this will make some improvement. There's going to be improvement to the lactic acidosis. So this is going to be the initial fix. Now, what about anti-infectives? Why is this going to be incorrect? Well, we know that antibiotics are for infections, especially if there's going to be a wound that we're going to worry about later on. And what we have here is metabolic acidosis. This is not caused by the bacteria. It is from the low oxygen and fluid loss. And so the anti-infectives will not really be the best fit here. And it will not fix the acid problem at all. This is going to be indicated for other complication. Again, this is a wrong focus. It treats infection, it doesn't treat acidosis. Now, high flow oxygen here, it's something that might be administered through a simple mask or a cannula to help if the patient's lungs aren't working well, or maybe there is low oxygen saturation. But in burns, the acidosis comes from hypovolemia and poor tissue perfusion, not just from the low oxygen level. And the fluids will fix the root cause, and the use of the high flow oxygen would not resolve this one. And so consider this one as a supportive measure. It is not the initial treatment for this acidosis. Again, look back into the clue here. The initial treatment for metabolic acidosis includes administering. So, the supplementation of oxygen will not treat the hypovolemia issue, which is basically the core problem why the client is developing metabolic acidosis. Excuse me. Now, the last sentence here. Additionally, blank will be given to prevent Clostridium tetanus infection. And the options we have are amphotericin B, tetanus toxoid, piperacillin, tazobactam, and vancomycin. Now, what do you think about the best answer for this? Well, this is going to be the tetanus toxoid. Why is it? Well, remember that burns can leave the areas open, and this will now cause some growth of some bacteria. And one of those is the Clostridium tetani. This can grow into the dead tissues, and we know that tetanus is deadly. It can cause muscle lockup. And since this patient's vaccine history for the tetanus is not known, a tetanus toxoid shot is given to this client to boost their immunity and also to prevent the tetanus infection. And this is also a standard care, especially for this client who has a burn. Now, what about amphotericin B? I want you to remember as much as possible what this is. Well, this is a strong antifungal drug, and this is indicated for candidiasis or aspergillus. And take note that the concern here is about tetanus infection, which is caused by a bacteria, not a fungus. So the amphotericin B will do nothing to stop the infection, Clostridium tetani. And again, this is something that will be used for a totally different issue. And this is not going to be considered as a burn prophylaxis. Main key takeaway for this option, it is the wrong type of treatment for the wrong type of microorganism. Now we have piperacillin tazobactam. What is this? Well, this is a broad spectrum antibiotic that can kill many bacteria, like those in wound infections. But the tetanus prevention needs a vaccine, a toxoid, not an antibiotic. And we know that antibiotics treat active infections, not prevent tetanus, which require immunity. So it's a good drug. It's just not the best fit for this job. Now, what about vancomycin? This is a very strong antibiotic that can fight gram-positive bacteria such as MRSA. It might kill Clostridium tetani if an infection were active, but the prophylaxis that we are talking about here is about stopping it before it starts with using a vaccine. Plus, the vancomycin is not routinely used for tetanus. It is indicated for other infections, and that's why we're going to discard the vancomycin here as well. So, let's recap everything here and apply those test-taking strategies per blank. So, for blank 1, what you need to do here, since the focus is about preventing hypertrophic scarring and contractures, the patient should be wearing the device for about 12 to 24 months. The word here is to prevent. It's asking how long it takes for this device as part of the treatment to deal with in preventing the hypertrophic scars or the contractures. Now, what about blank 2? What is the focus here? This is basically wanting you to point out what caused the drop in the blood pressure. So, also don't forget about the time frame, which is 18 hours after admission, that there is a significant blood pressure drop. Remember that within the first 24 hours to 40 hours, there is going to be fluid shifting. And that is the most dominant issue that you should be worrying here. And there is no other cause other than the capillary leak syndrome. And this is going to lead to the shifting of the fluids from the vascular compartment to the interstitial spaces. This can lead to hypovolemia and shock, and also low blood supply to the vital organs, especially the kidneys. And the other options don't really match the timing of the context, because we know that sepsis typically arises days later, not within hours. And the inadequate fluid replacement is an outcome of the burn's initial damage, not the root cause. And the PCA hydromorphone, which is a pain medication, doesn't cause significant blood pressure drop linked to the burns. And also keep in mind that major burns are closely tied to fluid loss, and there's no other option here. Again, capillary leak is the early classic cause for this issue. Now for blank 3, the key here is finding the cause of metabolic acidosis, as stated here, right? And so you have to recall the pathophysiology regarding what causes the metabolic acidosis. Again, this is the buildup of the lactate that's causing lower pH, and it's because of the fluid loss caused by the capillary leak. This is going to starve the tissues of oxygen. It's going to end up producing lactic acid more and more, and the other options don't really fit here, such as the impaired blood flow, though it kind of sounds kind of similar, but it doesn't really target to the main issue, which is the oxygenation, the anaerobic metabolism. And the especially in the early burn shock and hypovolemia, it can cause oxygen shortage. And so matching the low pH and the high lactate in the blood gas results is very important here. Now for blank 4, what you're going to need to do here is to point out into the initial first step. Okay, it says here, initial treatment for metabolic acidosis includes administering blank. And you have to choose that intervention or action that will address the cause, right? Again, it is the hypovolemia, and so we are going to select the IV fluid administration. This is the first intervention to fix the cause, which is the low blood volume, and this will boost the blood flow and it will cut acid buildup. Again, the other issues, anti-infectives, it's gonna fight infection, it's not gonna fight acidosis. The high flow oxygen, this is going to help with the breathing, but it's not going to help with the fluid loss. The sodium bicarbonate is used in the extreme cases, but it's not our initial action here. All right, it's not our first go-to treatment. Now for blank 4, our strategy here is to look for that action that will prevent Clostridium tetanus infection. Okay, remember that this is a germ that grows in dead tissue like burns, and so you have to eliminate individually the other options here like Vanco, piperacillin, amphotericin B. These are medications that are intended to treat other complications, not about preventing the tetanus infection. All right, so I hope that you're getting all the necessary rationals here. And so that is the end of our session today. I want you to keep practicing, stay confident, and remember you're closer to that RN license with every step that you are taking. So, if this session helped you, do not forget to like and subscribe to this video for more NCLEX preparation tips. And also drop your questions in the comments, and we'll see you in the next session. Remember, you've got this.